Okay. Start. Okay, Michael, we are all started. You can go ahead and get going.
Great. Good afternoon and welcome everybody. I'm Michael Shifter, president of the Inter-American Dialogue, and I'm very happy that all of you are able to join us for this very important and timely event on innovating healthcare in Latin America and the Caribbean. I'm sure all of you are happy to take a break from the vote counting that is still taking place, and until we have a declared winner, I think it's good to focus on very, very important issues like this one. We've had a very strong response from the members of the dialogue as well as key stakeholders. So I'm very, very thankful to all of you for tuning in. A recent World Bank survey shows that in the midst of the coronavirus pandemic, the treatments for non-communicable diseases, cardiovascular diseases, cancer, diabetes, and the like have been severely disrupted globally. In Latin America, which, as all of you know, has been struggling as much as any region of the world with this virus, is no exception. Many countries have sought to keep at-risk populations away from the contagion sites, such as hospitals treating COVID-19 patients, because they are particularly vulnerable to the effects of that disease. As a result, treatments and diagnoses have been delayed or missed, unfortunately, with dire and often costly consequences that have not yet to be fully assessed, have not yet been fully assessed. In the face of these challenges, health experts have been calling for new methods and systems to help care for people with non-communicable diseases in the context of COVID-19 and its aftermath. I'm very grateful that 4 experts have agreed to join us today to discuss these issues and address these questions. Their bios have been posted on our website, so I won't go into detail for each, but let me briefly introduce them in the order in which they will speak. Rifat Atun is professor of global health systems at Harvard University. Rocio Saenz is a former health minister of Costa Rica. Amanda Glassman is executive vice president and senior fellow at the Center for Global Development. And last but not least, Rolf Hanger is the Latin American head at Roche Pharmaceutical. And I want to thank all of you for joining us and being here at this event and sharing your insights and expertise. Each speaker will give introductory remarks followed by a Q&A session with the audience. If you'd like to ask a question, you can use the Zoom Q&A function, or you could submit your questions via email to meetings@thedialogue.org or on Twitter using the hashtag LAC Health Systems. We look forward to a very interesting and productive discussion. And before I turn it over to Rifat, I would really like to express my deep appreciation to Eric Brand, who's the director of the Dialogue's corporate program, and for Kate Blancet, who is a coordinator for development and external relations at the Dialogue, for their enormous contributions in making and organizing this event and making it possible. So thank you all very, very much. And with that, let me turn it over to Rifat to get us started.
Thank you, Michael. Thank you, first of all, for the opportunity to the Inter-American Dialogue for inviting us to this panel, which is very, very timely. And thank you for your excellent framing of the session and some of the challenges we face in relation to COVID-19. I think it will be instructive to maybe revisit that, revisit some of these consequences of COVID-19, but also also look at the characteristics of the region, why Latin America is so special in relation to its characteristics, and think about some of the innovations that need to happen. And first of all, with COVID-19, we're facing a number of effects. The first is direct effect of COVID-19 on individuals that is leading to morbidity as well as mortality in the affected groups. But in fact, larger than that, and we're now seeing this in many countries, is the consequences of delayed care or inability to access services because of the restrictions introduced or the physical distancing, or because of the low capacity of the health systems to provide care in these challenging times. So there's a huge backlog of care, plus much of the care that's going to be needed is going to be for individuals in whom delayed care would have led to complications or late presentation of conditions. So we're going to experience a tsunami of demand going forward. The third is the social consequences of COVID-19. Because of the economic crisis that is currently hitting countries, and that will likely to persist going forward. Now, these consequences are particularly going to hit Latin America particularly hard because of certain characteristics. The first is that Latin America is one of the most unequal regions in the world in terms of income inequality. Secondly, there are very substantial inequalities in relation to access to health services. And this has been compounded by COVID-19. The third is there are the safety nets in many of the Latin American countries. In fact, I would say most Latin American countries are not strong enough or adequate to account for the social consequence of COVID-19. And the fourth is that there are many people who are in informal employment, and the technological platforms are not there to enable them to go back to work. And if most of these individuals are not able to go back to work, so they will not be able to earn income, and then that's going to put them into a vicious cycle. So clearly something needs to be done. And we're seeing the terrible consequences in many countries of not just rising cases, but very high levels of mortality in Latin American countries. Well, clearly we need to rethink about the responses that are being mounted at the moment. First of all, health system responses, and secondly, the social and economic safety nets that need to be in place. But I'm going to focus on the first, and maybe we can discuss the second and third aspects as part of the panel. Clearly, we need to innovate in health systems. One of the important features of Latin America, which I did not mention, is that the demographic and epidemiological transition has happened very quickly. And that has brought chronic illness very quickly. So the levels of chronic disease, non-communicable diseases, and cancer have risen very rapidly. But on the other hand, health systems have not been able to transition to new models of care delivery to manage this large burden of chronic disease. So we need to innovate to ensure that the systems are strong enough, but also oriented in the right way to manage the burden of chronic disease, and also the backlog that we currently have. That's going to require investing substantially in primary healthcare, but also investing in technology and innovative diagnostics and medicines to ensure that people are able to access them. Now, if we look at the innovation patterns globally, not just in Latin America, there's a lot of innovation happening in relation to new diagnostics, new medicines, new health technologies. So there is a real renaissance in science and great innovations coming through. So we're seeing lots of delivery of innovations, but we're not seeing innovation in delivery, i.e., the health system delivery models have not really changed for decades, if not for centuries. So where these innovations coming into systems that are no longer fit for purpose. So we need to think how we can combine the technological innovation with innovation and delivery to develop new models of care. Now that's going to require new partnerships. It's going to require bringing together the public sector with the private sector who has experience and expertise in innovation, along with investors, innovators, patients, and civil society to really to develop a collective response, because this is a challenge for everyone. As they say, we're in it all together. Now, there are some efforts in the region, for example, Movimiento 2030, that is trying to do just that, trying to bring together multiple stakeholders to create an ecosystem for innovation. Not just generation of innovation, but very importantly, the scale up of innovation. So this is where the governments come into play. They need to support these innovations that are coming through, including international financing agencies, to ensure that innovations are scaled up to have impact. Now, I see much opportunity, but also a great need for innovations to be delivered in Latin American context, but also scaled up to impact populations. Thank you.
Great. Thank you very much. Thanks for getting us off to a terrific start. That was excellent. Why don't we move now to Rocio for her comments. Rocio?
Yes, good afternoon, and thank you for the opportunity to be here with these wonderful panelists and this important dialogue. I think it's following the thoughts from Rifat. I want to add some ideas about the importance of the women in the Latin America. I think we have to allocate the women as a first target population in our health system. I think it's also very important to take in mind that the poverty is affecting more women, and of course the informal sector is more increased in the women point of view. And this COVID-19 is charge more heavy weight in the shoulders of the women. And for that, I think is the first idea I want to allocate is that we have to prioritize the women health and the women workers, health workers. And when I am thinking about the health workers, I am thinking about the community health workers, but also at the hospital level. And for that, for me, it's as a woman and leader from my country and from Latin America, I think to keep in mind the prioritization of the women is a very important to think. And maybe sometimes it's not exactly the innovation, but we have to thinking how to approach this with the women at the center. And the other thing I want to add with we have in Latin America, most of our health system are fragmented and segmented and under financing. And right now with the COVID-19, the health system have to arrange to attend the COVID-19 and also to attend the chronic disease. And for that, I want to tell you that when we are working in that and thinking in this presentation, I say we need more money, but also we need to spend this money better and look for be more effectiveness, not only efficiency. And this is the second idea I want to share with you. And the third idea in the first intervention is we have in Costa Rica a program that we call Navigators. This is a very important program that is coming with the university, NGOs, and also the health system. And the Navigators is a survivorship women with breast cancer. We build the information from them, and we try to accompany them and support the women to the health system. And we found that the different barriers that the woman has to affront and take in mind. And this barrier, some of them Rifat mentioned yet, was the very panic that the patient have to go to the hospitals, because they know they were a vulnerable group and they don't want to avoid to be with COVID-19. And sometimes the women tell us, I prefer to stay at home without the treatment because I don't want to die alone at the hospital. And I think the information that we have before and after is really amazing. Normally we detect some or capture around 112 women per month before the COVID-19. During the quarantine fell to 79, and right now it's only 38 women we are captured. And for that, as Rifat mentioned, we have a big wave of patients. This is an example, a wave of patients that they are waiting for the treatment, diagnosis, and to be attended by the health system, but also for the whole society. I will leave my comments here and wait for the next.
Wonderful. Thank you, Minister. Thank you so much for those very useful, interesting comments. Why don't we turn now to Amanda Glassman?
Michael. So just to echo what Rocio has been saying and Rifat, the needs and demands on health systems in Latin America and the Caribbean were growing very dramatically before COVID-19. The share of the poor of the total population has been about the same over the past decade, but the total number of the poor has been increasing. And that means more demand. And both poor and the rich are living with multiple non-communicable disease risk factors, or frequently undiagnosed and unmanaged non-communicable disease, and an enormous amount of premature death and morbidity that affects productivity and well-being. That was before COVID-19, but it also told us a little bit about the vulnerability of the region to COVID-19, which we're seeing in the excess mortality estimates. And prior to COVID-19, as Rocio mentioned, the health systems were basically underfinanced. With some exceptions, although there have been nominal increases in spending over time, there has been very little real growth in public spending on health, despite growing need in the form of an aging population, the growing number of poor, and this high prevalence of risk factors and NCD that we've talked about. Of course, there are the exceptions, Costa Rica being one of them, Colombia, but there are some issues around the efficiency of that spend that we can talk about. Sapal has shown that 17 countries in Latin America spent around 1.5% of GDP on health in 2000, and that amount had increased to only 2.2% in 2018. So not much at all. And the Caribbean has been spending about 3% of GDP over the last 2 decades, no growth whatsoever, despite the changing demographics and risk factors. The other piece is the out-of-pocket spending. You would hope to see that as universal health coverage reforms evolved in the region, that out-of-pocket spending on healthcare would decrease. And that hasn't been the case. It's been very steady over time, even in countries like Brazil that had fairly well-performing public system of care that they hoped would be universal. Still about half of spending is out-of-pocket. So what does that mean? I mean, when we saw if we're talking to a US audience mainly, you probably saw the pictures from Guayaquil in Ecuador at the early part of this outbreak of people who simply can't access hospital care because of cost or not having the right to certain kinds of services. The other piece of this is that they're underinvested in cost-effective interventions, low levels of screening and poor outcomes in NCD. We already knew before COVID that 1/4 of non-communicable disease deaths were happening in people under 60 years old. And public health was like the forgotten function. In many countries, it was decentralized down to lower levels of government that had low capacity to execute, and we're living with the consequences today. So COVID-19 shows up. We're already in a difficult situation. Many of the countries were already in economic problems. And the economic shock has been enormous. It's enormous in terms of its impact on public revenues. It's enormous in terms of its effects on poverty. Both of those are issues that the government has to deal with now. And when you look at the IMF is tracking what governments spend on. You see that most of the public spending response is happening on social protection, as well as firms, bailout to firms, cash transfers, things like that. But health system spending has not increased enormously. And that is very worrying. It would be great to understand a little bit what is going on in order to cope with this, if we really want this terrible crisis to be a moment to leap forward. The other aspect of this is that much of the response is centered on hospitals. It's always been about 70% of public spending on health in Latin America. This is where the drama has played out. And yet, outcomes in hospitals were not great before. The IDB did a study on adverse events in hospitals in a couple countries in the region and really found very high levels of adverse events and poor quality of care compared to OECD and other places. And then finally, I just want to end with reflection on the COVID crowd out, as we call it, sort of the collateral effects of COVID on other health problems. There's not a huge amount being written about this right now. But there are a couple studies, one from Brazil that basically is showing that stroke admissions were halved during this period. In Argentina, there's been a 75% drop in emergency room visits in a sample of clinics, a 48% drop in hospitalization, all of this related to cardiovascular care. So we will be living with the mortality and just human consequences of this crisis for some time. And I'll save my comments about the innovations and methods that we would hope to see for the next round of questions. Thanks.
Thank you so much, Amanda. Appreciate it. Before I turn to Rolf for the final opening comment, let me just remind all of our participants to, if they have questions, to use the Q&A function in Zoom, the event hashtag on Twitter, or you can email questions as well to meetings@thedialogue.org. So let me turn it over to, we already have one question, but we two questions. Look forward to others, but let me turn it over to Rolf.
Yeah, thanks, Michael, and thanks to Amanda, Rocio, and Rifat, and the opportunity to be on this panel. Because I really believe that this kind of spaces where we exchange experiences and perspectives are very important and very valuable. Now, I think we all are pretty clear about what we are facing regarding the COVID experience, the pandemic that has shown to us, and I think the lack of preparedness that actually happens in our health systems in the region. And I think what you obviously go back to, it's things like the short-term vision that actually exists in health systems. And I think several of these issues has been mentioned. I think most of our systems, they're not doing the preparations, the prevention, and it's basically on sick care. And I think that affects us as well. And the fragmentation that you see in many of the health systems, I think the work that leads to the silo work and obviously, I think we all know that the lack of financial resources and the lack of investment in health, that actually leads then that innovation is not used, that innovation that could probably even reduce actually costs by spending more on prevention as well in this respect. But I think this all has this impact that we face at the moment. And I think what I see and what we see very often is as well, it's an enormous lack of data and good data. So we actually don't know exactly what is the situations. We don't have really good quality data and as well have follow-up data. I think that's another point that we need to look at in future, that because I think the more we have a data-driven data analysis, the more we will be able to offer our patients, our populations better care. Now, when I look, and it's already mentioned, I think Rifat and Amanda and Rocio, you mentioned, I think the big case is for us is it's the profile of the patients in Latin America. They are more now basically on NCDs. And if you then think about what has happened actually, if you already before we haven't really fully diagnosed all the patients, and our business is a lot as well in cancer, but if I look at it, it is that we always saw that we should have theoretically so many patients that we could treat early, and how much of them we really had in the system. And now we know we have data of several countries that something like the diagnosis rate is 80% down or even more. So we have seen this data throughout the region. because of the fear of going to the hospitals. And I think this is extremely worrisome, because if I look then at what is happening, is that we know we have data, we have economic data showing that, for example, in a breast cancer patient, a breast cancer patient that is diagnosed late costs probably the double than in treatment and in the care that he needs, and the one that is early detected. And all these patients are not detected. And I think this is something that really is worrisome. And Rifat, you mentioned, or we mentioned the tsunami that is probably coming afterwards when we are through this. But the problem is that we probably have then much more severe diseases that we detect, because we detect the patients late. And I think that makes a big burden on the system. And I think that's probably not enough talked about. And I think that's important. Now, the question that I always ask myself is, well, okay, we know the diagnosis. Now the question is what we can do about it. And the probably give a start. And if you think, because it was mentioned, Rifat, you mentioned as well, the collaboration between the different parties and the private public partnerships, I think they're more and more important. And I think that there are clear examples what can be done. Some of them are, for me, the learnings that we can afterwards use into the system. Some of them were very early on. We got from government some help, some requests for help, and saying, okay, and then very short, very fast, we managed to get chatbots up. We managed to get people aligning up to help for the hotlines for the governments and things like that. We obviously know that hotlines is just a tool, but at the end, what you do, we can screen patients through other means first, so before that, not everybody has to go to a hospital or to a clinic. But afterwards, when you think about this, it goes further. So what we managed to do and what we managed to organize is say, okay, how do we transport the patients? Because if, for example, an institution was separated for COVID or non-COVID, what you could do is to put the safe transport line in, which we control, which we test, so we can see that the patients arrive to the hospital that actually doesn't have. Or in Chile, what we managed to do is to say, okay, we have a pool of patients that we know that are treated, so oncology patients, multiple sclerosis patients, and others that would normally need to come in for controls. And what we managed to do is to get an agreement with the government to have telemonitoring, so the patients are monitored at home. And as well, if they need something, they are treated at home so that they don't have to go to a potentially infected hospital and things like that. But I think these are the examples that I think is showing the potential of these private public partnerships that help us to say, wait a moment, we probably need to just adapt regulations that help us in order to get further into more effective care. As Rifat mentioned, where we happen to be on the same board of the Movimento, and this is exactly one of the initiatives that I see. How do we manage to get the stakeholders together so that we can discuss and bring the innovators into the system so that we can find the solutions as early as possible and as fast as possible, so that we have a vision of 2030 medicine as soon as possible for our patients in Latin America. And that means probably a lot of technology, a lot of use of technology. Even when there is an overinvestment in hospitals, I think we all know that compared to other regions of the world, we probably have, even for the future state and the future development of NCDs in the region, actually not enough hospitals, not enough hospital beds. And so when we can decentralize, when we get a better primary care system installed, I think we will have a lot of more capacities when we use the technology that is out there. But I think this is what I see where these partnerships and this is going, and where it's important. I will stop here for the discussion.
Great, thank you very much, Rolf. We have a number of questions now coming in. There's certainly a lot of interest. Let me start with one that I'm not sure who wants to take this, but it's on the laboratories that we've heard a lot of discussion about laboratories that are specific to COVID testing and vaccine development. But we know that patients with underlying health conditions are at a higher risk of morbidity and mortality. How have laboratories in Latin America addressed laboratory capacity to conduct coagulation testing, hematology and ESR testing, blood gases and other testing that are essential to differentiate COVID from other underlying health conditions. Who would like to take that? Anybody?
I'm happy to comment,
Okay.
maybe not specifically on the tests that have been identified, but maybe a more general overview in relation to laboratory capacity, which tends to be, which in the countries, many of the countries is highly fragmented. And so the first, and often inadequate. So we need to rethink the diagnostic capacity and capability. And I think this is where partnerships can play a very important role, because there is no reason why private sector entities cannot invest in the development of laboratory capacity and for the public sector to purchase these services. And we already see examples of this in relation to radiology. And the same principles could be applied to laboratory services. What's important is that the assets in the country are used effectively and efficiently. And who provides the services should not matter so long as these services are highly cost effective, which means that they need to be efficient and effective and lead to outcomes. But the public sector needs to develop appropriate contracting instruments in order to have these services and to respond. But this is one of the big challenges in Latin America, in that there are a lot of rigidities. So we are talking about innovation, but innovation is not just in technology. Even when there's innovations in technology, they have to be used for these innovations to benefit individuals. In many countries, even the health budgets are not executed. So each year, a large proportion of the budget goes back to the treasury because the budgeting process is so complicated. In one country, which I will not name, to get a budget execution, one requires signatures from more than 10 people. And even when the budgets can be executed, the budgets themselves reflect their what we call historic incremental budgets. So they tend to reflect the past as opposed to the current and future needs. So that needs to change if we are serious about strengthening health systems and transforming the structure of the health systems. Otherwise, we are really locked into past structures and past problems. This is why the systems have not been able to respond.
Great, thank you.
Probably I can add to this.
Yes, please, Rob.
Obviously, I think we are providers of part of the COVID testing and all this, and I think what we have seen is very clearly, so that's not something that you build up overnight. That's something that you need to prepare, because and I think Rifat mentioned a point that I think is very important. I think that you need to look at, in a fragmented health systems, you need to look whether it makes sense that every of these fragmented systems needs to have their own, or where you actually can do central testing, where central of this. And there are some examples in Latin America where this has happened, and actually that helps in order to get better throughput, that you get better results, faster results. And I think, but if you don't reverse early and you will not be having something for emergencies like happened now. And I think this is something of the lessons that we've learned in the COVID pandemic.
Great, thank you.
I would like to add that it's very important to take in mind that the health system are providing services. And to provide the services, the health system needs the products, like the testing, like the human resources, like the drugs, like the papers and internet. But I think the most important innovation that we have to make in this after the COVID is how to provide these services in another way. The way the services is more effectiveness, there is more warmer with the people, more close to the at home. And for that, I think is the moment to recognize that the primary healthcare has to be really incremental and be analyzing how is the role of the primary healthcare. We need the people healthy, but we need also the people who has a disease to be treated in a good way with the good products, safe, and also be involved in their own treatment. And I think we have to really rethinking what is we are calling the model for the services, and also thinking more broader, like we have to move to how to provide the services that the people really need. And in this time, I think the COVID bring us the opportunity to rethink this.
Great, thank you. I have. Let me ask a set of questions. We have 3 questions that all have to do with the Caribbean, and let me put them together and see if anybody would like to respond to either or all of them. The first one is by John Oswald and has to do with Cuba's healthcare system. Can you assess their healthcare system vis-a-vis chronic diseases and especially the COVID-19 pandemic? There's another question specifically on Haiti. If anybody knows the COVID situation in Haiti, Brian Merriman asks, and also he says, I have heard that they have had very few cases, but I wonder if the reporting there is reliable. And Rosamond Adams asks, the small island developing states in the Caribbean, I assume meaning the English-speaking Caribbean, healthcare systems are already overburdened. COVID-19 presents an additional shock. How can these countries invest more in NCDs and health when they are facing such a slow economic growth? So those are 3 Caribbean-related countries. I don't know who would like to begin to address that. Amanda, do you have any thoughts? Or?
Well, I mean, I would just start by saying that the economic crisis is just pretty dramatic in the Caribbean with the shock to tourism. So, you know, that it's likely that the collateral from COVID due to the economic collapse it might be more serious than COVID at this time. We do see some benefit from being on an island and being able to control entry and exit in terms of COVID-19 cases. So, you know, as long as you're doing the right things, it should conceptually be possible to reduce the number of cases. But as many have noted, the amount of testing going on and the ability to understand whether, you know, what is actually happening in terms of the explanation for the level of excess deaths makes it very difficult to say what's going on. And, you know, the level of risk factors in Caribbean islands are well above even the regional average. So that would suggest that they would be hit by COVID-19 in a particularly hard way. But that said, so far, the big issue is more on the economy side than on the health side, as far as I understand it. But maybe others have other insights.
Okay, thank you. Anybody else want to weigh in on that?
Well,
Yeah.
I think health and the economy are inextricably linked. And I think the mindset needs to change in relation to health. Yes, there's an economic crisis, but if the economy is going to grow in the future, one needs to invest in health, because we are seeing the consequence of A, underinvestment in health, and B, suboptimal investment in health. We've not been investing in the right things. As a result, we have the wrong structures. We don't have the right kind of human resource mix. We're not using technology optimally. In many cases, we have no idea what's going on because we really don't have the data systems or the analytics. Now, so when COVID comes, lo and behold, it's not surprising that the systems are not responding because they're not functioning. You know, let's call a spade a spade. I mean, most health systems are really broken. So I don't think there should be an excuse for not investing in health systems. There is a critical component of economic development, economic growth, and sustainability. And it's not a trade-off. So to get to really have a V-shaped recovery or any recovery at all, one has to invest in not just in sectors that is going to lead to more buildings or roads, but actually, very importantly, human capital. This is really critical. And I think the sooner we understand this, the better we'll be able to get the benefits. But I want to reflect what Amanda and Rocio earlier said, critically important, the investment needs to be in the right places. We need to change the structure of the systems. We need to change the processes. We need to invest in cost-effective interventions that can be delivered in primary care in the community, and innovations that can really empower individuals, because they're the most important agents for generating health. We cannot solve our problems in hospitals. By the time someone presents to hospital, it's too late. That's really a failure of the system. So I think we need to have a fundamental rethink about investment in health, and not see it just as an expenditure.
Yeah, I agree very much with that. And actually, I'd like to ask Michael, you know, as we look at organizations like the Inter-American Development Bank or the World Bank, what do we see in terms of health system response? I see a lot of lending going to buy PPE and test kits and things like that. But do we see these kinds of investments and scale up? I mean, what should we be looking for from the international community? Maybe one of the other panelists or Michael would want to reflect on that.
Yeah, no, I think I think there needs to be a lot more innovation in the bank cooperation as well, and I think there has to be a lot of beyond sort of financial support, also technical advice and sharing expertise than we've seen. I mean, I think this has been a sort of a wake up call, and I think there's been an awareness that there's been a lacking, although these institutions clearly have health programs, but it really needs to double down seriously and do something more systematic and more structural, because there are real underlying problems. So I think it's hopefully they will move in that direction.
I want to add something about the digital records for the patient and for the community. In the case of Costa Rica, we have we call EDUS, es Expediente Digital Único en Salud. And that means that we have information from the community. We have information for the nominal person of each household. And also we have the information for the people who need the care, the healthcare. And I think if we can use this information fully to really look for stratification the people by risk and focus the intervention depend or related with the different kind of risk, we can prove like the graduation of the different intervention. For instance, if we are looking for the diabetes and we have some like 11% of prevalence, we know not all the people who has diabetes, we know. The first one is, if we don't know, we have to look for the people who are not yet know it's a diabetes. The second moment is, if the people know has a diabetes, but has another risk factors, obesity, hypertension, and then you can build some kind of different intervention and deliver the services different than the people who doesn't have the possibility to control, only to lose weight. And for that, I think we have to rethink this primary healthcare angle at the community, and try to health education, to empower the people to take care of their own disease, and of course to be healthy, that I mentioned before. But also that we think about is the gap that we have about the internet in our region. Not all the people have the opportunity to have the cell phone, the smartphone, the internet. And for that, when we are looking for the innovation, maybe also we have to look for how to reduce this gap for the internet. Even if we don't have internet, we have some idea how to use the message, the WhatsApp, and another kind of issues to the people can't inform to the health system how they feel. And I think we have to move a little bit around from the facilities and to look from the communities, close to the people.
Great.
Thanks a lot. I think what I like very much about this topic in the data and is even if, for example, from the pharmaceutical industry, we want to go to the Ministry of Health and say, look, there is an innovation and we need, and you have something like, according to the data, so many patients, and we make a deal, or so we make a managed entry agreement or whatever, and things like that. That's only possible when we have reliable data. And for us, I think it's interest of both sides, from the industry and from the Ministries of Health, to build a database so that we can actually talk at the same language and then say, look, we minimize risk for both of us, so of both parties, and saying, look, we are going to treat this many patients, and if it's more or less, we know the statistics, and you know how much you're paying, and we know how much we have to deliver and add to this. So I think data is actually a backbone of what we need, and I think I've traveled extensively in Latin America, and I've seen as well. So when we have the post somewhere in a rural area and that notes down the things on paper, how do we know whether all this data and the statistics and then where decisions are based upon are really accurate? And I think this, so I think that's a very important point that we need to address for the future.
Great. Thank you. Let's turn to a question by Molly McCabe. She asks, if 70% of government spending on health goes to the larger hospitals in Latin America, what barriers exist between government healthcare funding and the smaller clinics and primary care providers? And are there ways that Western doctors and international health institutions have tried to get involved that have actually proved counterproductive or even detrimental to the systems in Latin American countries?
I want to add something in that. Maybe it's important, when I was a minister, I have the pressure for the doctors, for the hospital. And I learned that it's important to all the population, the health workers, we have to recognize that there is not one choice and another. We are a whole health system. We need all the parts of the system working good, well, and on time. And for that, I think we have to change the message that sometimes, because the people feel if we prioritize the primary healthcare, is because we don't believe in the hospital. If we prioritize the hospital, is because we don't believe in the primary health. And we have, all of us, the professionals of health and the economic people, has to change the mind and look the health system as a whole. It's a unique system, it's not part system. And for that, I think it's important. I would like to invest each country, if each country can invest 30% of the budget in primary healthcare, could be a very good goal. Because normally it's 80% of 85% in the hospital and less than 10% in the primary healthcare. This is impossible to look at a system like a whole system. It's like we are fragmentation. We are doing the fragmentation inside of the health system. And I think we have to change this way that we are looking the health systems.
Great, thank you.
I think that I'd like to maybe follow up on that. Again, it's not, we have to have hospitals, we have to have primary care and community-based care and person-centered care. I mean, individuals are the most important contributors to health. The current problem is that because primary healthcare is weak, Much of the activity that takes place in hospitals is actually activity that ought to be managed in primary care setting. So we're managing common problems in very expensive settings. It's like using a, I don't know what analogy to use, but it's like using a very expensive car to take you from A to B rather than just walking there. So it is, maybe that's not a good analogy, but I'm sure you understand what I'm trying to say. So, so the image around primary care needs to change. In Latin America, often the term used for primary care is derogatory. It's called atención básica. So it's one's mind is like the basic level that is not attractive. So where the best trained people should work in hospitals. Actually, it should be the reverse. 95% of healthcare can be managed outside hospitals in primary care, but that requires high quality, technology-enabled primary care with family health teams or primary care teams. And that should be possible. Of course, we need hospitals, but the investment patterns need to change. But we're locked into these budgets that reflect past structures. Once you have a hospital, you're committed to it for 30, 50 years. So it creates rigidity in the budgets, which is very difficult to get rid of. So much of the investment becomes indiscretionary, which is a challenge.
Great. Please.
Yeah, just, I think we really have to think about an agenda, even before talking about an innovation, is for people to really acknowledge that there's a problem and this requires attention, because the health sector is not a high political priority, or had not been prior to COVID. And the reason why there's not much spending reflects that. And the durability of the out-of-pocket spending in the private sector by much of the population is also an expression of that the quality is perceived better in the private sector in some countries. Costa Rica is definitely an exception in this case, but even in Brazil, if you have money, you don't go to this public clinic. So, I think we have to think out of the box about how it is that we could get to those communities and countries. Some countries have good systems established, and most of the first contact that a person has when they're sick or for prevention is at the basic community level, but in many cases not. So, are we really thinking about a big reform here, and who would lead it? I don't hear the leaders of the countries articulating this need. I see us in an emergency coping situation and not thinking about reform and innovation for the next phase. So I think the question is, who will articulate that agenda, who will move it forward? Because the political economy is very complicated, as Rocio says, getting people to think about it as a system, trying to focus on what the patient experience is rather than sort of just servicing the different interest groups in the system. It's an ongoing struggle.
Great, thank you. I'm going to ask two questions together, although they're distinct. There's a relationship there, and just see who would like to respond. First is from Andrew Rudman, who asks, in the US, telemedicine use has expanded exponentially during the COVID-19 pandemic. How can governments and the private sector collaborate to address the digital divide, which Rocio just mentioned before, issues that may inhibit greater use of telemedicine in Latin America? And another question by Karen Bell, who asks, many hospitals in the US are now learning the value of networks systems for improving budgeting, quality of care, and sharing lessons learned. Are there examples of hospital administrators and public health leaders forming networks and meeting regularly, even if virtually, to share lessons and develop ideas for coping with crises and improving care? Who would like to start one of those? I don't know. Rifat, do you want to talk about the public and private and the telemedicine?
Yes, absolutely. I think it's a really excellent question. And as they say, never let a crisis go to waste. What would be very sad is to go back to business as usual and not really sustain and scale up some of the innovations that have taken place. I mean, telemedicine has been around for 20, 30 years. And what is interesting is that COVID-19, this shock has actually accelerated the adoption and diffusion process. So there's an opportunity to bring on board technology players and private sector and others to ensure that one is able to develop solutions, and that this will enable the transition out of hospital-centric care to more primary care and community-based care that is focused on maintaining and improving health, enabling and empowering individuals. And that will be highly, highly cost-effective. So now, for that to happen, regulations need to change, because regulations tend to be years behind technology. So one needs to create this enabling ecosystem for these innovations to be adopted. But for that, the budgets need to change and the payment models need to change to incentivize uptake of these innovations.
Okay, great. Any other thoughts on those questions?
Well, I think I can add here. So what we have seen is, and I live in Brazil, so I think in Brazil before it was actually not allowed, and now after with COVID, there is a regulation. What we have seen in other countries as well. So the conversation about what is actually possible in order to as I mentioned in my introductory remarks, what we managed to do in Chile. So that distant monitoring of patients, and if you look at it, what actually technology gives you. So I think we are all developing apps, and there are apps out there that are all what is all in our pocket. And if you look at it, I think that enormous opportunities to have the detection of diseases or detection of deterioration of symptoms, you can have them in your pocket. You can have better transformation of this knowledge to the doctors. You have better use of the time of the doctors. And I think this is all what is coming, and absolutely agree. I think regulation is the key to it. And we just need to make sure that we don't fall back when after COVID passes to say we don't do this this telemedicine, or we don't adapt the emergency regulations that pass into permanent regulations. And I think that I think is a very important topic.
Okay, thank you.
And also the training for the people, for the innovation, I think is very important. The regulation, but also the incentives and the training, and how to use this opportunity that the COVID are pushing us with the telemedicine, and now we have to keep all the stuff and the ideas. For instance, like delivery drugs at home for the people to care this at home. And I think we have to build some kind of case studies to take in some good practices and bad practices also, try to learn about that, and then to share with the people who are really in front of the patient. Because this is the way. It's not only the national view. We have to improve the innovation and the research also at the community and primary healthcare, not only at the hospital with high technology.
Great, thank you. We're really approaching the end of our time, and unfortunately, we're not going to be able to get to all the questions. Let me just ask one final one very quickly from Beatriz Nice, who has asked, what about a COVID vaccine? Is there real possibility of a Latin American developed vaccine? Anybody have any thoughts on that?
So,
Amanda?
yeah, I mean, I do think probably some of the Latin American research labs will be involved in an eventual COVID vaccine, but of course, it really depends on whether those vaccines get into the COVAX portfolio that is being managed by this consortium out of Geneva, the WHO, and others. Or, Operation Warp Speed, obviously, in the US has its own arrangements. But I think, whatever it might, if a Latin American country wants to promote its own candidates, and if there are promising candidates, a key, that's an opportunity for public-private partnership, obviously, with the biopharmaceutical companies to do trials together. To be a country that hosts clinical trials, I think would be great. And I think that some Latin American countries are doing that. If you host the trial, you're more likely to get vaccine afterwards. But I think we've also seen Latin American countries signing agreements with Russia or China to get some share of doses from those sources as well. I think what's really important is that the countries figure out what is going to be a good value vaccine for their health systems, given what the outbreak looks like. If it's a very expensive vaccine that requires multiple doses, that's not going to be something that you're going to be able to buy at large scale. It will be expensive. And the other question is, are countries even budgeting for this expenditure? This is something else that I haven't seen. I've seen commitments, but what I haven't seen is sort of money in the bank, acts of Congress in place showing that the government is ready to buy and what they're willing to buy in. So I'll stop there. I'm hopeful, however.
Right. Great. On that note of hope, anybody else want to weigh in?
Just very quickly. Again, this is an opportunity for public-private partnerships and also international partnerships. As Amanda said, many countries are actually trialing in sort of phase 3 trials some of the vaccines developed elsewhere, but countries in Latin America have been developing vaccines. For example, Instituto Butantan has licensed technologies through product development partnerships, and they produce millions of doses of vaccines that the Brazilian unified health system uses. So I think through partnerships, one can develop capabilities and scientific excellence to be able to not just test vaccines, but also to produce them. So partnerships are key.
Great, thank you. I know that Rolf wanted to weigh in as well.
Yeah, I think on the vaccine, I think it was all said already, but I think what is important, we are not in the vaccine business, so it's not something that we came across. But the interesting thing is I've come across at least two organizations that approached us for developing treatments that potentially can be used. It's too early to say.
Hello?
Locally developed and locally produced products out of Latin America for the world.
Okay, great.
Yeah.
Thank you.
Only one
Rocio,
more.
we'll give you the final word, Rocio.
One more. I dream that the Latin America has the opportunity to produce the vaccines, not only to testing and to be autonomous. And for that, we need a global collaboration to transfer the technology for our countries.
Wonderful. Thank you. That's a good note to end on, I think. Rocio, Amanda, Rolf, Vivat, thank you all for your excellent contributions and for sharing your insights and expertise with us this afternoon. Really very illuminating. We have a lot more questions, but we unfortunately don't have time. My apologies to those whose questions I didn't have a chance to pose, but I think that just means we're going to have another session on this because there's a lot more issues to discuss, and obviously there's enormous interest. So I want to thank all of our participants as well, and also a final thanks to my colleagues at the Dialogue, Eric Brand and Kate Blancett for their help in coordinating and organizing this event. And with that, all of you, I hope you stay well, stay healthy, take good care of yourself, and thank you again for your support and your participation in this event. Take good care.